This is our second panel discussion on the afternoon here and on the growth and future of telemedicine. My name is Shawn Parker and I'll be moderating this panel. Was the chair of the FSMB Workgroup on Telemedicine, and I serve as a at-large director on the FSMB Board of Directors, as well as a public member of the North Carolina Medical Board. Prior to the pandemic, we were already seeing significant growth in technology and familiarity on the use of telemedicine, but clearly in the COVID environment, that exacerbated its growth and use, which caused a lot of issues and challenges to medical regulators. In response, our House of Delegates directed the creation of the Workgroup on Telemedicine, where we were tasked to go back and evaluate the prior 2014 FSMB policy on telehealth called the Appropriate Use of Telemedicine Technologies in the Practice of Medicine. And that work group met and has made its recommendations, which will be considered Saturday at the House of Delegates. So what we're here to do today is we are glad to have experts, some healthcare policy experts, physician representation, who are going to tell us a little bit about what the landscape is for healthcare, for telehealth, what's the future, give us some insights that way, and maybe we'll touch a little bit on the revised policy as well. Our format, we're going to start out with an initial discussion, but really want your engagement, and we'll open it up for questions probably at least halfway through. For those who are streaming at home, or wherever setting you are streaming from, feel free to go ahead and submit your questions as you have them, and we'll try to incorporate them either in the discussion or as appropriate during the opening question and answer session. So without further ado, let me introduce our esteemed panel here. Kwong is a nationally recognized expert on telehealth policy. She is the executive director for the Centers for Connected Health Policy, which is a federal designated national telehealth policy resource center. In that role, she has written numerous policy briefs, crafted state legislation, and led several coalition efforts to help assist states with their telehealth policies and efforts, particularly in the areas of Medicaid and public health. Kwong helped create a language that became the basis for the 2011 California telehealth law. She's published articles in various peer-reviewed journals and is the co-creator of the center's 50-state Medicaid telehealth reimbursement survey. Very glad you're here with us today. Also with us is Dr. Jack Resneck. He's a practicing dermatologist and health policy expert as well. He also serves as president-elect to the American Medical Association. He was elected to the AMA Board of Trustees in 2014 and chaired that Board of Trustees in 2018 to 2019. As a strong advocate for physicians and patients, he chaired the AMA's Council on Legislation. He's a member of the editorial board of the Journal of American Academy of Dermatology and is on the board of directors of the National Quality Forum. He serves as vice chair and professor of dermatology at the University of California at San Francisco and has a joint appointment to the Philip R. Lee Institute for Health Policy Studies. So again, a very skilled and thoughtful panel we have here today, and let's hear from them now. Maybe if you don't mind, just to open up, anything I left off of the introduction that would be beneficial, and what created your interest in this area of healthcare policy? May?
Well, actually, I sort of stumbled into telehealth policy. My background before the Center for Connected Health Policy was actually in education and early childhood issues. However, I was looking for a change in career, and actually a friend suggested that I look into a new organization that was opening up, which was the Center for Connected Health Policy, even though I didn't necessarily have an extensive background in health policy. What I did have was an extensive background in California legislative issues and legislative processes. So I was hired because of that and was basically thrown into the deep end of the pool with telehealth. And since then, that was about, at this point, 13 years ago. So from there, I really did develop the expertise on telehealth policy. So you also have to understand CCHP, when I was hired, was focused primarily and was created to focus primarily on California telehealth policy. But we became a national organization with funding from the federal government back in 2012, and we've been serving in that capacity ever since.
Dr. Resneck?
Well, I just want to start by thanking Shawn and the FSMB for the invitation to be here. It's great to be back on a physical stage and sitting in one of the comfy chairs here. And I've spent the last 2 decades in California, but I'm a native Louisianian, so it's nice to be home here in Louisiana. So as Shawn mentioned, in my day job, I am a frontline physician and a dermatologist when I'm not doing my AMA work, and licensed by one of your member boards, last I checked, hopefully still so. And so dermatology is a specialty that really got experience with telehealth fairly early on. There's a lot we can do in dermatology in terms of telehealth, so I had some early exposure. And one of the things that motivated my involvement was really noticing problems not in licensure at all, but in coverage. So what we were experiencing in the years sort of pre-pandemic was I would see a patient. Sometimes people, I work at UCSF in San Francisco, and so patients might drive from 2 or 3 hours away, come see me, we'd make a diagnosis, we'd start treatment, and there would be an opportunity to use telehealth maybe to do their follow-up visit and their medication management once we had seen them and established that diagnosis. And there were many times when their insurance wouldn't cover it. The insurance would cover the patient using some online telehealth provider that didn't have access to their medical records, and they'd get connected to somebody who often wasn't of my specialty, sometimes wasn't a physician. So I think that really motivated my early involvement.
It's interesting. Now, often payers unfortunately drive a lot of healthcare policy, or at least healthcare activity. So Dr. Resneck, as a leader of the AMA and as a practicing physician, what are some of the things you're hearing or experiencing currently in the last 3-4 years on telehealth?
Yeah, it's difficult to use the word silver lining to talk about anything associated with COVID. The pandemic has been a horrific couple of years. But the last couple of years have left me with a few other things as well. One is just an enormous sense of pride about my physician colleagues around the country and your licensees who, instead of running away from this fire, have run towards it and put their own lives on the line every day, despite sometimes patients disputing the science and evidence that they're talking about, sometimes spitting at them in the ER, facing threats of violence. So that's been one. And another, so I'm being very proud of colleagues. Another thing is that I have really seen telehealth during this pandemic to be a success story. And as all of you probably know and remember, in the first couple of months when many physician offices were shut down, we saw this dramatic opening of telehealth, really led by the federal government and Medicare opening up coverage and some licensure changes as well, but coverage. And it led my colleagues around the country to really start integrating telehealth into their practices in big ways. You've heard the stats in several presentations earlier today. And one of the things that happened as we did that is it advanced our knowledge on the ground about what it's useful for, what it's not useful for. We've established a lot more standards of care for telehealth. Again, coming back to my small specialty of dermatology, that patient I mentioned with a chronic medical issue, doing medication management follow-up, it was perfect for that. The next patient who was coming in who had a history of melanoma, had their surgery, doing fine, but needed a full body skin check to rule out any new skin cancers, to check that their lymph nodes were okay. Not ideal for that. I needed to see them in person. So I think we learned a lot. Patients started to get used to it. They got used to the technology. They could log in more quickly to our various portals. I would start actually seeing the patient instead of the dog running by in the grass when I was doing my telehealth visits. We saw improvements in access. So not just the things you think of as obvious about rural patients who maybe have decreased access to care, but inner city patients, historically minoritized and marginalized communities who were getting improved access to care. So big improvements there. And another thing, I had mentioned earlier that previously there was a lot of growth in telehealth of this sort of more corporatized, separate from their established healthcare system. And that was really addressing a lot of convenience care. But we started to see telehealth these last 2 years really used where there are the biggest gaps in care, for chronic disease, for hypertension, for diabetes, for substance use disorder, for mental health issues. So I think that was a big upside of this expansion and coverage. There are some licensure gaps, which I think we'll get to later this afternoon, but it was really exciting to see this success in the last couple of years.
Certainly patient familiarity and physician familiarity, and then the obvious, the various stakeholders that are driving it. So in the work you've done the last 10 years, all this tracking of legislation, what's happening now? I mean, I guess their voices are being heard to some extent. There's quite a bit of legislation introduced recently. What are you seeing?
Yeah, there's been a lot of legislation introduced. For those who aren't familiar, CCHP tracks both on the federal and the state level, so that means at a minimum 52 different jurisdictions, so it's all 50 states, the District of Columbia, and what goes on the federal level. So on the federal level right now, we're tracking about 200 federal bills that have some telehealth associated with it in some ways. A lot of it really to do with the waivers that they made temporarily during the pandemic. On the state side, we're tracking probably around 250 different bills in the 51 jurisdictions there. And what we're seeing is, if I were to categorize sort of like the general issue areas that they're focusing on, a lot of it is really around coverage, like what is going to be paid for, what's going to be covered either by the Medicaid program, Medicare program, or what they're going to require commercial payers to pay for. And that can be broken down into like separate issues such as location of the patient, where they are when the telehealth service takes place, the type of telehealth provider providing the service, and what services are covered. And sort of more interestingly, and this is one of sort of the unexpected things to pop up during the pandemic, is the issue around audio only. So if you had spoken to anybody in telehealth pre-pandemic and you asked them, is audio only telephone a part of telehealth, you probably would have had them say no, because it was explicitly excluded in a lot of jurisdictions, either in how they define telehealth or in their Medicaid policies. So that was not considered underneath the umbrella of telehealth before the pandemic. The pandemic changed that, and really to policymakers' credit, they recognized, well, not everybody's going to have access to live video, so we need to have a channel for them some way, so they allowed audio only to be allowed. The question now is, there's actually a lot of questions, but the main question is, should they continue to allow that to happen? And right now, policymakers are trying to balance it, not only with audio only, but with other aspects of telehealth policy of, we don't want to restrict access for patients who may need it, but how do we ensure that the patient is getting an adequate, good level of care through this type of modality that we're going to allow? So that's probably where it starts becoming close to the issues that you all are very interested in, is like what services are covered, also what do they think is sort of, effective care, which really is the policymaker qualified to answer that question, or should it really be more left to practitioners who are actually practicing and providing services? So that's where the balance is starting to now happen in the policy discussions.
So the audio only is a good example where our 2014 policy actually, as it described what is telemedicine, it kind of said audio only is not. Mm-hmm. And I think the revised version moves that towards the same needle, that actually, if in the clinical judgment of the physician that they can meet the standard of care and determine that through a proper evaluation and assessment can be done through that means, then that it can be appropriate. And to our point of the policy trying to address issues of making sure it's equitable, meaning you don't want to exasperate the issue, then the use of telehealth has to be available broader than where just our major metropolitan areas, which even themselves sometimes have trouble with internet. It's not always just because of the geographic location. So audio only is a good example. We heard this morning from Admiral Levine that the federal government's still pushing behind, so probably can see for the short term public payers being there. The commercial payers, where are they falling on this?
That's a little bit harder to determine. Over the years, CCHP has actually tried to get commercial payers policies around telehealth, and there have been some who've been very open with it. A lot of them have asked, what do you want it for? And it's like, well, we want to make it public so people know. And he said, no, or we're not giving it to you. So it's a little harder to determine exactly what all of them are doing. But the sense I get is commercial payers, a lot of them have been, or some of them at least, have been a little bit more progressive with their policies than maybe what you've seen with public payers. So it's been kind of a mixed bag. I know there's been a lot of articles saying, or that are reporting that certain health plans are pushing telehealth perhaps a little bit more towards their enrollees or to their customers more than what you would maybe see from like the private payer side. But I think it's sort of like, it's quite undetermined, and I would say it would probably be like, as I said, a mixed bag of things.
And as a physician or the physician organization, what do you need from commercial and government payers to know about what's important here?
I think we need some certainty to be able to plan around the future and the next several years, and to retool our practices to be able to seamlessly integrate telehealth into the care that we provide, right? Telehealth is not a service unto itself. It's not like a procedure that has a CPT code. It is just another way to deliver care. So, you mentioned audio only. We think that needs to be covered, particularly to address equity issues. If anybody is primarily delivering telehealth via audio only, that's probably a warning signal, though, that, it is a backup option that is really important for people who don't have access to broadband or who don't have access to an iPhone. But it's generally not our first choice in terms of delivering care. So in terms of coverage, which I think was the question, we need some changes at the federal level. Medicare, at the beginning of the pandemic through the CARES Act, basically allowed during the public health emergency for us to be able, you may recall, or if you don't know about this, the old Medicare rules basically said that if you're not in a really rural area, you can't do telehealth. And even if you're in a rural area and you can get telehealth paid for, oh, by the way, the patient has to go to a presenting site and can't do it from their home. So what we all think of as telehealth today didn't fit into that Medicare paradigm. And we don't want to see that access to care yanked away from all of our Medicare patients. So we're very appreciative that Congress last month passed an extension that'll keep this going for 5 months after the end of the PHE, but we really need some permanence there. And there are a number of bills that we're supporting circulating in Congress. May mentioned commercial payers. We do not want to get back to this world either where our commercial patients don't have access to telehealth, or if they do have access to telehealth, can't use it with their existing healthcare teams that they know and that they trust. That's another thing we don't want to see is we don't want to see commercial payers basically using access to a separate telehealth network as an excuse to sort of say, oh, well, we've met our network adequacy requirements, right? Just because you have 3 of this specialist and 2 of this specialist somewhere multiple states away in your telehealth network doesn't mean you have checked the box of network adequacy. So patients and doctors who have a sense for what's best in any given instance about whether to be seen in person or be seen by telehealth, we think patients and doctors need to continue to make those decisions and have them covered.
Can I just tack on there to a comment that Jack just made regarding the commercial payers? One thing that we are seeing some states doing with their commercial payer laws around telehealth is to avoid that. They are citing in there, like, you cannot essentially funnel your patients into a third-party telehealth group. You have to allow your in-network providers also to be able to use telehealth and reimburse them. So we are starting to see at least policymakers recognize that as an issue, and there were a couple states before the pandemic that were doing that, but we're seeing that become like more frequent occurrences through the legislation that's going in there. And also to echo what Jack just said is, telehealth is not a separate service, it's just a tool. So it really should be left to the provider who is there with that patient, dealing with that specific scenario right there, to decide along with the patient whether this is really the best way to deliver care.
Yeah, I like that. I think the work group really was stressing that it's a modality, it's not a specialty, and the standard of care is the same. And I think actually one of the hot issues in telemedicine is the ability to prescribe and making sure you're seeing that standard. And where I serve in North Carolina, a lot of our discipline issues that come up with prescribing, it's poor prescribing no matter where it is. If it was in a clinical setting, this was still poor prescribing. It's not just by using telemedicine it's caused it. The greater issue, though, is the expansion of poor prescribers to citizens in North Carolina. So speaking of that, the licensure is probably the next hottest issue after payers on how do you license a physician using telehealth. Obviously, our gold standard, our general practice is it's where the patient is receiving care is where the physician should be licensed. What are you seeing from the legislative aspect on that, where obviously the waivers early on, but please.
Yeah, that's also been another interesting development with the pandemic, along with the audio only, is that it was also always an issue that was brought up among the telehealth community before the pandemic, the licensure issue, because telehealth obviously allows you to cross state lines fairly easily. However, it really wasn't on the radar for a lot of federal policymakers, and the interesting development has been they're starting now to talk about it and introduce bills that have some sort of licensure impact. Now, a lot of them have been very narrowly focused, such as extended beyond the pandemic for like a bit of time, or when there's like a national public health emergency or something, then allow a national licensure waiver of some sort. But the fact that they're now sort of looking into that on the federal level when it's really in the state purview as to decide what the licensure issue should be or what the licensure rule should be is a significant development. Now, on the state level, so far, at least during the last 2 years, the legislation has primarily focused more on perhaps joining licensure compacts as opposed to changing licensure laws. But we did see changes in 2 states where they created a telehealth registry. So that was in Florida and Arizona as well. So that was something different. And we're also starting to see the creation of perhaps a telemedicine license, which is actually kind of ironic because those were starting to be phased out. They were pretty prevalent, at least when I started doing the telehealth stuff, like over a decade ago. And they were starting to phase out gradually and just said you just needed a license. There was no telemedicine or telehealth license. That's starting to make another reappearance here. So you have like perhaps a telemedicine registry. Again, only really 2. I think there was a state that just introduced something, but like just a couple of states, and then sort of increase in a special telemedicine license, but really more has been focused, at least on the state level, on the compact issue.
Yes.
I think at the AMA, we believe very strongly that physicians need to be licensed in the state where the patient is receiving care, period. This sets rules of the road so that we know how to comply with state medical practice acts and know how to provide care that is consistent with the needs of each state. It allows states you all to do your jobs to investigate patient complaints in places where you have jurisdiction to do those investigations. The thought of a federal telehealth license and patients going to somebody in the District of Columbia to file their complaint, or the US Congress setting the rules of the road for reproductive health care, medical marijuana, end-of-life care, age of consent, all those things that are established in your state medical practice acts terrifies me. So I'm a big believer in state license. We're going to talk, I think, in a few minutes about some things that that you all can do to update state medical licensure to create some narrow exceptions to actually help telehealth flow a little bit better. But we're still big believers in the location of the patient setting that licensure. We are strong supporters of the Interstate Compact. We're now, I think, up to 37 jurisdictions, 35 states and a couple of other jurisdictions that have joined the compact. That is the way, I think, to help physicians be able to more easily practice in multiple states. Where they're done properly, small regional compacts, I think, can make sense as well. I know from the physician community, one of our asks would be that maybe the fees, once you've got your anchor state and you're applying in more states, maybe having some reduction in those fees. would make it easier and maybe not give people pushing for federal licensure that argument. So that would be a big ask. We're pushing Congress to refund the HRSA grants that I know have helped several of the states out there to put in place compacts. So we're a big believer in that as well. And we can talk in a minute, I think, about some of the exceptions we're hoping for.
Yeah, that's right. So the work group really worked on this area as well, just to try to be forward-thinking. And I think what it did a great job doing is actually articulating exceptions that I would have already said were the rule. So de minimis care on it's a continued patient relationship that's just temporarily out of this jurisdiction, or even for a period of time, like going off to university in another state, how that should not neglect their ability to see their family physician that they've seen for the last 18 years. There's also certainly consulting and a high-level specialty care, and all those things that the work group in their recommendation recommended to go ahead and articulate that should be okay, but not codifying that, saying this is allowed and this is not, because we really, we don't want our legislators doing that. We want to use clinical judgment and allow for that flexibility that way. May, do you have any thoughts on licensure in state or where the patient is versus where the physician is?
So you touched upon, so for those who don't know, CCHP underneath our federal grant, we have to provide technical assistance to. Specifically, it was meant to be to the other telehealth resource centers, but we just basically answer anybody's question when they ask us. So a lot of questions around licensure that we get actually do touch upon what is in those draft guidelines that have been prepared by FSMB. So Shawn touched upon some of them, such as, the kid going off to college, which was like a big question I got at the beginning of the pandemic. And I got those, interestingly enough, from policymakers. So I had congressional members and state legislative members asking me, either I have a constituent or somebody on my staff, their kid is saying, they're being told they can't receive services from their student health program. So that was like a big thing at the beginning of the pandemic. So addressing the issue of somebody who's maybe temporarily in another state for whatever reason, for school, or maybe they vacation somewhere regularly for a couple of months or something. So that being addressed. The other one that was also addressed in those draft guidelines that we get a lot of questions on are clinical trials, because that's always been like kind of a gray area with telehealth. And when CCHP gets that question, it's like, well, technically it does sound like you would have to be licensed, but there's really nothing there specific to clinical trials. So I think it is helpful that that was addressed too in those guidelines.
I would say, while we don't like legislators or regulators getting into putting details of standards of care in print and inking them in permanent marker because those things change over time, we do think that there are some common sense changes that make sense in the licensure space for some of those areas that maybe haven't been enforcement priorities, but as a practicing physician, I would like to know that I have the blessing of my state medical board to do. Which is why we at the AMA, and I think the profession broadly, really feels like the FSMB draft document that's coming up before your House of Delegates this week just did a fantastic job. I should disclose I was on the work group, so I'm biased here. But I think the FSMB broadly, under Shawn's leadership, with this work group, did a great job of balancing some common sense changes with some other things to make sure that based on what we're seeing out in the community and on the front lines to balance some safety and quality issues. So if it's okay, I'd love to mention a couple of those.
Sure.
Because you're going to be reviewing these in the next several days if you haven't already. So May mentioned a couple of these in terms of codifying some exceptions to the patient location. So if you have an established relationship that was formed while the patient was in your state and you're doing routine follow-up care with that patient who has not permanently left but has temporarily left your state, be it for college, for vacation, or they happen to have homes in 2 or 3 places, or those kinds of situations, and in your judgment, you're not opening a new can of worms with some major new health problem where they really need a local source of care, it would be really nice to have that codified, that that's actually a continuation of care and that that's okay across borders. In addition to that episodic follow-up care, we are hearing from a lot of sort of centers of excellence around the country where a patient is exploring going to a different state to get sort of tertiary or quaternary care, or maybe a surgery, maybe a big workup. And it just makes sense to have one preliminary visit with the healthcare team at that center of excellence to see if they're a good fit before they spend the money on airfare and hotels and time away from work and all those things. And as long as that person is not assuming responsibility for care and starting prescribing, that exception makes sense as sort of a one-time pre-care exception. The flip side of that is if somebody travels for care and gets their surgery or care across state lines and then goes home, that for some period of time that center of excellence could continue. We heard about clinical trials as well. But on the flip side, we have seen things in telehealth that have raised some pretty specific quality and safety issues that I think are well addressed in this document too. And I don't think that this document in any way creates a higher standard for telehealth. It just calls out ways in which telehealth needs to meet the same standard of in-person care and using that as a gold standard. So one is just transparency. I see patients all the time who come into my office and say, oh, I need to see you. I tried via telehealth to start off. I use this web company. Well, I'll say, well, who'd you see? And they say, oh, I think a dermatologist. And I start to look into it, and it actually, maybe often wasn't the specialty they think. The person wasn't board certified. The person wasn't in the state where they thought they were. So just basic transparency. When you walk into a physician's office, you know where they're located, and typically you can sort of see their credentials locally. So transparency is an important piece to call out, which this policy does. Taking a meaningful history. So this can be done via telehealth, right? So whether it's a live video visit, whether it's an iterative, interactive, non-live process where you're pinging questions back and forth, this can be done very well via telehealth. But if your telehealth service is one where a patient is filling out a quick questionnaire to get a prescription, and 100% of the time that questionnaire leads to the prescription they asked for, or they started with a prescription that they put into a shopping cart and the telehealth visit comes at the end to approve that medication, that's probably not high quality health care and probably not getting the patient what they need in a safe way. We think that there are ways I can review great images via telehealth, but again, if 100% of your visits don't require an image or video, and again, there are exceptions, mental health doesn't always need an image, right? And often doesn't need an image. But if that would be the standard of care and you would want it in person, or if there's an ancillary service like a lab or radiologic study. And then the last thing that I see most often is sort of what I think of as a version of patient abandonment, where somebody uses a distant telehealth provider, and again, this can be done really well with chronic conditions, but they get sort of a one-time prescription for their diabetes or their psoriasis or whatever that's not going to be gone and cured in a month, and there's no follow-up plan. Or there's no relationship with physicians in the area where the patient is if they do need to show up locally and get a biopsy. So I think the policy, the draft policy, does a really nice job of laying out both some areas where we can maybe loosen a few things around follow-up care in particular across state lines, and also clarify what high-quality telehealth looks like.
And if I could clarify, which is an attorney's way of saying correcting something I said completely wrong just a moment ago, the codification I don't believe we want to see in law, and for the reasons you said. But what we've done in the policy, the work group policy, is created a resource, and we do hope that the state boards will adopt something along those lines so that they can give that clarity to their licensees, setting that expectation, because that's what will drive better healthcare delivery. So we're almost we're a little past halfway point. Quality of care I think is a real important issue. Equity also is an important issue. So maybe at this time let's, do you have some comments relating to quality of care concerns? I think you spoke to a little bit of the standard of care a little earlier, and that being laid out in some legislation.
Yeah, so what's been really interesting to see, and we were discussing this a little bit before our panel started. So as I mentioned, CCHP tracks what goes on, not only in state law regulations, but what goes on in Medicaid policy. And really, the whole question is like, do you want a policymaker really starting to, set the standard of care? Because a lot of times, not all of them are physicians, so you kind of wonder if they're really the best people to start setting those standards. But what we're starting to see as things are starting to be a little clearer what the landscape is going to look like in a post-COVID environment are certain arms or groups that are doing things such as perhaps setting sort of policies that is a little bit creeping more towards standards of care, which is not typically an area that these groups have typically touched upon. For example, like a Medicaid program outlining in their Medicaid policies, like these are the standards of practices we're going to expect someone providing telehealth services to abide by if we are going to reimburse them. Now, so far, we've only seen this happen in one state, and they have kept it fairly broad and vague, but typically what we saw before the pandemic was more sort of, if they had something like that, was just sort of a general statement of like, follow the typical standards of care that you would do if you were required, if you had provided in person. And they would like leave it at that one sentence. This is actually a little bit more specific, still kind of broad, but as a policy person, when I see that, that raises a flag for me. Especially when you're talking about telehealth policy, because it has a habit of starting to replicate in other states. And to see a Medicaid program do that is just, I'm marking it down as something interesting, and maybe it's a one-off, but it is starting to maybe encroach upon other areas or what other groups typically do. So it's something that I just wanted to make folks here aware of, and that you guys might want to keep an eye on that. We definitely are. We'll definitely make it a little highlight if we see it occur in more than one state. So that was just one thing I wanted to bring up, is you're starting to see a little bit more involvement from policymakers. And policymakers, when I say that, do not just involve state legislators. It could involve other groups who touch upon how telehealth is covered, how it's delivered, and how it's reimbursed.
Thanks, May. I come to any conversation about health equity humbly and recognizing there are people in the audience I'm talking to with lived experience that I don't have, but also somebody who looks at the evidence and recognizes the tremendous inequities that we have and feels a responsibility, and that we as a profession have a responsibility to rid our health system of those inequities. The AMA has invested a great deal in the last couple of years, created a Center for Health Equity. We're staffing up to 50 employees at this point who work under Aletha Maybank, who leads that center. Last spring, we put out a document, a very lengthy document, really looking at how we would like to redo all the work that we do across silos at the AMA. So whether we're thinking about our publication group, whether it's medical education, whether it's litigation, whether it's advocacy, that this not be siloed in one part of the organization. And also reckoning with our own history as a 175-year-old organization that has contributed to inequities, that looking back at the Flexner report and the damage it did to historically black medical schools, looking at many other things in our own history in order to build trust with marginalized communities. One piece of this is in the innovation space, and I think of telehealth as, it's not brand new, but one piece of the innovation space. And everywhere we think about health equity as it relates to innovation, I step back and ask some basic questions. And what's become clear to me is that if you don't start with an equity lens, whether it's AI, health apps, telehealth, if you don't start with an equity lens, there's the potential for any of these new technologies to actually cement existing inequities or to ameliorate them. So whether it's making sure we cover audio only, whether it's making sure that Medicaid covers telehealth, whether it's making sure that we expand broadband access, all of those things are important. The tools have to be designed in ways from the beginning to make sure that we're broadening access to care and stomping out inequities.
Thank you for that. So I think we can kind of summarize this last section here, or kind of wrap up this last section. If you think of what you said, that when we talk about policymakers, we quickly go to lawmakers, legislature, or the federal government or agencies, but our state boards are great policymakers. And actually, I believe they're the appropriate people to be crafting this policy. So if what would you recommend to a state? What should their policies include to ensure that we've got safe, effective telehealth modality of practice available to constituents in their state, and that doesn't exacerbate inequalities and ensures the quality of care is high? As like a 3-compound question there for you, so you're welcome.
I think Jack actually outlined some very good points there when he was talking about equity, of really looking at it through the lens more of, government tends to look at it as a lens of like, oh, we need to contain, as opposed to like, are we getting the services that we need to the people who need it most? So, and that's going to be really hard to like shift them on that. So the way to shift them that I found to probably be one of the more effective ways is to really work with a widespread group of folks in the community. So working with really kind of not the usual suspects, like maybe the healthcare suspects, because there are different groups that are impacted and interested in telehealth that can be very great allies, but also help provide you with viewpoints that help you shape like the best policy possible for the largest groups of people. And some of the things is, weighing in like, how different populations would access healthcare and what are the channels that are needed to like access those channels, whether it's like an audio only because maybe they're in an area where they don't have broadband or they can't afford broadband. But another big thing, especially with telehealth, that I think has been lacking even before the pandemic, and to an extent sometimes in the pandemic as well, is an education piece. So coming into the pandemic, I would bet if you had spoken to anybody not in healthcare and said, like, what do you think about telehealth? They would not know what you were talking about. So patients or the general public has gotten really sort of more of a crash course on telehealth because of the pandemic. And right now, just sort of my Uber driver coming here yesterday from the airport, and he said, well, what do you do? And I said, I work in healthcare. And he goes, oh, what in healthcare? And I said, telehealth. You may not have heard of it. He goes, oh, no, I heard about it. And he proceeded to give me a lecture on telehealth. So, so it's become like, more familiar to people. But the thing is, it's like, who has educated them? Who has like provided them that information? Do they understand sort of like all the policies on there? I'm not saying go and talk to your mother and give her like a policy 101 on telehealth, but I think sort of like letting them know what it can do and what its limitations are as well, and how it can like provide the services goes a long way, not only to educating like the patients, but also to different groups who can be your allies, who can help you get through to policymakers and advance policies that really benefit the majority of people or as many people as you can with the technology.
Thank you, thank you.
I'm going to be brief because I want to make sure we have time for questions. So I would say the most important thing is, as we think about all the different policies that come before us in telehealth, in addition to thinking about an equity lens, one other thing I try to come back to is my own worry that some of the lousy examples of low quality or unethical care that are out there damage the really important great stuff that's happening in telehealth and digital health and AI. So I think about most telehealth policies as, is this policy going to make it easier for the people who are out there doing high quality work that actually addresses a real gap in care, as opposed to making it easier to get antibiotics really quickly for the sniffle that wasn't bacterial in the first place? And does it promote coordinated care rather than creating more fragmented care? Does it make it easier for that stuff to happen and a little bit harder for the stuff that we don't like to see happen? And so at the end of the day, that's the question I ask about most telehealth policy proposals. And I, again, with my bias of having participated in this process, I will say that our organization, the American Medical Association, is based on what the FSMB has put forth and is considering. It has our complete and full endorsement because I think it achieves that balance incredibly well. So what I hope states will do is I hope FSMB will pass this. I hope states go forth and get this in regulation so that we can continue to advance care and take great care of our patients.
I'll mark you down for the reference committee tomorrow. We'll make sure that gets to the record. But all right, so we have reached that time for some question and answers. We have 4 microphones, 1, 2, 3, and 4. Please just come right to it, and I'll do my best to recognize you. Yes, sir. Number 3.
Thank you. Tom Lee from New York. I would like to thank the Workgroup and the panel for an excellent talk. I would like to make a quick observation as a panel to chime in. First of all, you cannot have your cake and eat it too. That's what I've always been told, right? So when it comes to telehealth, interstate compact versus network adequacy, I think you're going to step out exactly that. I think many of our friends in the insurance industries are certainly going to take full advantage of it, as you've already seen it happening. Now, I think, though, we are conflating 2 different issues. One is telehealth coverage and payment. And the second one, which we all advocate for, and second one is the standard and care and quality of care, which most of the body's membership here is somewhat concerned with. I know many have stated that it's the same standard, but as practicing physicians, most of us know that's probably not true. So it really behooves us. I would ask the panel to please chime in as to, for example, I as a neurosurgeon certainly can perform a neurological examination and make a surgical decision over telephone, let alone video phone alone. And last but not least, I would like to see the work group, I think it has to an extent, better define the acceptable platform and modality going forward so we all know the same rules of the game. Thank you all very much.
So thank you for the comments. I think one of the things I've learned is that I really defer a lot to specialties to establish their standards of care. And I have a lot of surgical colleagues where it's not immediately intuitive for me how telehealth works for them. And they say, actually for us, some post-op visits we now do via telehealth, and that's awesome. And no, maybe not my pre-neurosurgery neurological exam. So I really look to that evidence base that each specialty is building really as the standard of care.
So I agree with the statement that we are possibly talking about two different issues and they get mixed sometimes. Just a word of warning, policymakers do that a lot. So I don't know if Dr. Resneck's been following what's going on in California and like what's going on there with the Medicaid policies, where they are trying to perhaps achieve certain things and they'll put around certain restrictions. They're like, I don't think you're actually getting what you're trying to achieve there. So that is why it is also very important to hear from actual practitioners, I think, for policymakers, whether you're talking about an administrative policymaker like a Medicaid program or a legislator / congressional representative. Because they do sometimes when they're crafting the policy try to get to a certain goal, which is usually like very good and laudable, but the route that they take as far as crafting the policy is probably not the best way to achieve that goal sometimes. Like, again, I get back to telehealth as a modality, and that's why we do need the practitioners sort of to help color in those lines for us of like, where is this appropriately used and where is it not? That is like very hard to like write into policy. That's why a lot of times it's like great to see a policy that says, well, we leave it to the practitioner to decide if this was appropriate to use at that point.
That's right, within the specialty, within the locality, all of those things should still apply.
Just to quickly address the last part of the question around putting into the policy platforms, it's another one we get nervous about just because the platforms change and the nature of the technology changes so fast. So we're a little cautious about that.
I have number one, please.
Thank you. Thanks for your conversation, and thanks for the FSMB for bringing this topic along for so many years and staying nimble and evolving with the evolving challenges. So I wanted to bring up about federally employed practitioners. As you know, the federal government, well, not maybe the government, but Department of Defense is consolidating care around those who are in uniform and carrying that through to the Veterans Administration. And again, under the pandemic, use of telehealth has been extensively used. But now, as you go back to some of the rules within the states, those same practitioners are going to be challenged to be able to continue their care unless they're in specific settings. So if I'm in my clinic seeing a patient within a clinic in another state, it's not a problem. But if I leave that clinic to see that patient in another state, that could be a problem. So I'm wondering how that might be looked at. May not be able to be solved now, but to consider that, because soon there are going to be a lot of patients and families that will be under the auspices of federally employed practitioners and how that might be impacted by telehealth going forward.
Yeah, it comes up not just with VA employees or federally employed physicians, but even people who took care of patients under the exceptions the last few months, and now what to do with those patients as they transition. And we hope for some flexibility during this transition period, but we also feel like at the end of the day, particularly for non-federal, for non-VA physicians who are not practicing within a VA site, that it's important that those patients actually have some local connections to a healthcare system in their area. So we have, I know the AMA, there's some compromises that were reached around VA policy and VA physicians, because the VA does have the capacity to actually investigate across state lines and where the state medical boards don't. But we were a little nervous about the idea that anybody who provides any care to a veteran through a contract, for example, all of a sudden can now not have to follow state medical practice acts and not be licensed in the states where the patients are. So I totally appreciate you bringing it up, but I share your sense that this is a complicated area with complicated waters.
Even people like me who are active duty. That's why I'm bringing it up.
Yes.
On the DoD side, got it.
Any comments, May?
No, not really.
Number 4, please.
I am Yashwant Reddy from the State Medical Board of Ohio. During the pandemic, this telemedicine was good. We provided great care, which was very much needed. But going forward, I see that if we continue doing telemedicine care without seeing the patient in the office, I think it's not going to be a great care. It would be the minimal care we provide. And as physicians, we want to provide our patients great care. I would like your thoughts that in some states and all over the country, there are legislations which are pushing forward for telemedicine to become the standard. And as a provider, I feel at some point we need to see these physicians in the office to assess them.
You want to go?
I had heard this morning where kind of a consumer preference that it really spiked initially, but then as the pandemic waned, or at least the isolation component of the pandemic waned, that there are many people who still prefer to go in person, and there's a lot of great rationale for why they enjoy that relationship, or they feel more comfortable in that setting. So I don't think any of our policies are trying to drive anyone to that.
No, actually, I'm not. I don't recall anything either on the state level of it being set as the standard. It's just like another channel in which to get services, and it depends on like how big of that channel is it. Is it like narrow where it's like, oh, it's only going to mental and behavioral health, or you can have more services? But that is actually one thing policymakers are very conscious of, and I think I mentioned it earlier, in that they don't want people to be driven solely into telehealth. They do want it though as an option to providers if they want to utilize that to provide services. But there have been some policies where they require that at a minimum you do meet the patient at least one time if you're going to get reimbursed for them. For example, like the Medicare policies that CMS did for 2022 when you're talking about mental and behavioral healthcare services and like providing those services via audio only. They did write in a requirement having like an in-person visit with the patient at least once every 6 months or once a year, like afterwards. So as far as just having somebody solely within telehealth, I think policymakers are very aware of that, and we're not really seeing them like allowing that to be like sort of the standard of like you're only going to receive your services via telehealth.
Thank you. Yeah, we have one coming from online, and then I'll go to the 2 people at number 3. The question online came, were any of you aware of studies comparing the rate of complaints about telehealth visits versus in-person visits?
I know both complaints and malpractice claims have been relatively low, and patient satisfaction data are very high for telehealth, but I'm nervous about using that to really judge the net quality of care out in the world. I actually just saw a patient very recently who came in who'd had telehealth essentially by somebody practicing medicine without a license. And I urged them to contact the state medical board, and they're embarrassed that they used this site, and they're not going to contact their state medical board. And I see this a lot more with telehealth than with in-person health, where they just feel a little ashamed that they used site X, Y, or Z, and they're not going to file a complaint. So I think we need to figure out proactive ways to actually get a sense from our patients of of net harm. Again, the vast majority of telehealth, particularly when coordinated and being done by existing members of healthcare teams, high quality, great care, but for those unfortunate exceptions, we don't always hear about them.
My answer is no, I'm not aware of any studies, and I'm just intrigued with what you were just saying about people felt embarrassed making a complaint.
Yeah, I actually see this, I see this a fair bit, and it's this, people who've been harmed by prescriptions that they've gotten from kind of an online prescription mill who come in, but I really encourage them to reach out to a state medical board, but I more often than not, they're quite reluctant.
Wow. I can say we have not gotten a lot of those calls from CCHP, but we have gotten an occasional one. We do encourage them to contact their state medical board. And sometimes they're a little confused as to, well, what state medical board do I do? Because I was in Pennsylvania, but this guy's located in, Washington State. And it's usually like, well, better been licensed in Pennsylvania when he was providing that service. But definitely contact the Pennsylvania one and contact the Washington one as well.
Again, yeah, it's a difficult measure to say, the number of complaints equals quality or lack of quality. Number 3.
Hi, thanks for the presentation. So in the landscape of sort of states versus federal regulation of our profession, thinking about telehealth, which lends itself to a bigger, broader geography, and so FSMB and AMA have done a lot with the compact and with sort of suggesting guidelines that we should all be held to, regardless of what state we're in. I think about the CARES Act and sort of open notes and interoperability of EMRs, and I'm wondering what your thoughts are on where we could go with that, because as you so well put, it's the prescription of antibiotics for the sniffles by the doc in an app that drives you crazy as a clinician when you're seeing your patients, and you can't get records generally from any of the kind of those doc in the app type of places. So is there any work or thought being done, maybe even at a national level or certainly at state levels, for trying to make some interoperability?
Yeah, I'm curious
Standard.
if what May has run into around this. I mean, I have publicly pushed, particularly some of those large, mostly web-based companies, to proactively join interoperability networks so that I can see what my patients have been prescribed and what the basis for that was when they come in a few weeks later with a side effect of treatment. And there has not been much interest. What I get back is we'll do it when the patient asks us to, which is sort of contrary to where we've gone with the law and regulation and other pieces of this. So I take your point. It certainly would make it easier for us. Again, the goal here is coordinated care. The goal is having patients, there are times when it's appropriate to have lots of different members of a healthcare team engaged, and they may not all be in the same place, and we should be facilitating that. But it's best when we can see each other. I share your frustration when right now, when I go around talking to physician groups, the number one thing I hear complaints about, which is not our topic today, is that prior auth has gotten out of control, so I won't talk about that. But number one, until that took over, was I wouldn't go back to paper records. I like having an EHR, but I'm frustrated with my product, and I'm particularly frustrated that it has not solved the lack of interoperability. And why haven't we met this process, this hope? So I thank you for the question. I'm glad you brought it up.
Yeah, so the whole interoperability question, actually telehealth was not even a factor in the discussions a lot of time, which back when meaningful use was happening, I was bringing it up, CCHP was bringing it up, I was like, well, why aren't you including telehealth? It was almost like they were on two different tracks. I think it's only recently that light bulb went off. It's like, oh, maybe we should include this in the discussion. But as Dr. Resneck said, I don't think it's really gone deeply into those discussions there. I think just a couple of people have said, oh, maybe we should really think about this and how telehealth can be worked into it. So.
All right. Well, I'm afraid we are coming to our ending, and while I appreciate you being up there, I don't think we could give you a quality response before our buzzer goes off. And this reminds me of the old campaign days, watching that minute just click down and down. But I want to thank you both for attending with us today, and really for all your efforts you've had on participating with the FSMB. And